stop, have the dentist come in and reevaluate the patient. Okay, the patient has already been approved by that dentist. So the dentist has evaluated the patient, prescribed the use, and approved the use of nitrous oxide on that patient. Now, when you're providing nitrous oxide, you can only do it on one patient at a time. All right, which makes sense. How many times are you going to be cleaning two people at the same time? Probably never. Okay, so you can only be providing it for one patient at a time. You also have to remain physically present with that patient at all times. So if you drop an instrument and you don't have any more in the room and you got to go someplace else to get it, you got to get someone else to get it for you, okay? Because you cannot leave that patient while they're on nitrous oxide. And then when the patient is done, the dentist has to approve that patient to be able to leave the office. Okay? So let's talk a little bit about history. And these two guys are pretty notorious. They're both dentists, or they were both dentists. And at one point, they were actually partners. Horace Wells was the one who is considered the founder of modern anesthesia. So he is the one that first demonstrated the use of nitrous oxide as a medical tool. And he used it quite often in his office. He used it very successfully. He used it as the only type of analgesia that he gave to his patients. And he would use nitrous, and he used it successfully in his office. He was invited to go to a seminar with a bunch of physicians and medical students, and he had a patient up on the stage, and he provided nitrous oxide for that individual, and that person was getting a tooth extracted. Now, unfortunately, something happened and it wasn't administered correctly, and the patient cried out in pain. So he was booed off the stage, and he was treated like an outcast. So he ended up experimenting on some other inhalation medications, and he ended up getting addicted to chloral hydrate. And one day he was high on chloral hydrate, and he saw some prostitutes outside, and he threw sulfuric acid in their faces and was arrested. But they allowed him, before he went to jail, they allowed him to go back home in order to get his affairs in order before he went to jail. And he ended up killing himself before he went to jail. So he was fairly notorious. Yeah. William Morton, I said, was at one point a partner of Horace Wells. And he was the first one that actually published scientific data on the effects of using ether as an inhalation anesthetic. Now, he was notorious because he tried to make money off of it. Back then, when someone came through with some sort of a breakthrough treatment, it was common knowledge that you just let everybody know. You didn't make money off of it. And so he actually called ether by a different name, tried to patent it so that he could make money off of it. They found out what he was doing, and he was shunned, and so he was another notorious dentist. But he was the first to actually publish scientific documentation about the use of ether in medical treatment to use as a general anesthetic. I think he just died of old age. Yeah, I don't think it was something as big as the other guy. Okay, so when we look at nitrous oxide, we know that it's an inhalation anesthetic. You know, if you've ever had to have surgery, when you went into the operating room, they put a thing over your face and you breathed in this gas. You counted back from 10, you maybe made it to 8.5, and you were out. Okay? Those are also inhalation anesthetics. But we need to look at nitrous to determine, is it a general anesthetic? Is it something that can put people to sleep? Now, if you watch some of the movies where they give people nitrous oxide, you can see how it knocks people out. But we're going to see that it really doesn't do that, okay? So when we look at the scientific makeup of these inhalation anesthetics, ether was the original general anesthetic. And so this is the scientific equation of ether. Desflurane and sevoflurane are common general anesthetics that are used today. And if you look at their chemical makeup, you can see that there's some what looks like ether in both of those. So these are actually forms of ether. When we look at the chemical makeup of nitrous oxide, it doesn't look like ether at all. So if we're comparing just the fact of the scientific makeup of these inhalation gases, we can say that nitrous oxide does not match the other general anesthetics. So nitrous oxide is probably not a general anesthetic. And we can look at some other things too. First of all, let's look at the physical properties of nitrous. Nitrous oxide is colorless, it's tasteless. Sometimes it'll have just a slightly sweet smelling gas. For children, a lot of times they'll have the flavored nasal hoods to make it smell better, because putting something on a child's face sometimes can be kind of freaky for them. And so they try to make them smell good in order to be able to apply the nasal hood to their face. It is 1.5 times heavier than air. So if you turn a tank of nitrous oxide on, it's going to go down to the floor because it's heavier than air. It will not burn on its own. So you cannot light a fire using nitrous oxide gas. But if there's a fire present, it will support that fire to keep it going, but it is not flammable on its own. Okay? It is inert, which means when it goes in, it does not change. It goes into your body does not metabolize it to any kind of metabolites. It doesn't break it down in any way. It goes in, and then when it goes out exactly the way it was when it came in. Okay, so then there's different size tanks. And the tanks that we have are the E-tanks. So these guys over here, these are the E-tanks. So those are the ones that you kind of poured around on the little cart, just like our oxygen tanks. They're the same size as the oxygen tanks. There's also these larger tanks that are called H-tanks. Depending on the office where you work, if they have nitrous oxide, they are most likely either going to have it in an H-tank or an E-tank. If it's an E-tank, you're going to go into a closet somewhere, grab the unit, roll it out to the room, and set it up. If they have an H-tank, it's most likely their office is plumbed for the nitrous oxide, so they have hookups in the wall. So when you will just have the unit, you plug the unit into the wall. You don't have tanks attached to the unit. Okay? Now, when we look at the amount of gas that's in the tanks, if you remember back in medical emergencies, we learned that with oxygen in a full tank, we have 660 liters. And remember the PSI is 2,000. So if you had a full tank, it would say 2,000 PSI. And if it said 2,000 PSI, we knew that there were 660 liters of oxygen in that tank. And we could use that to determine how many minutes we have left. Remember how when we did that math? We're going to do it again. All right? With nitrous oxide, there's more gas in the same size tank. When nitrous oxide is put in the tank, when it goes under pressure, it turns to liquid. So in the oxygen tank, it's all gas. It's 660 liters of gas. In a nitrous tank, when they fill it up, because once it goes into pressure, it goes into liquid form. So a full tank, the same size tank of nitrous oxide, has 1,590 liters for the same size tank. The H tanks are about 10 times the size of an E tank. So if we multiply the 660 times 10, we'll know that an H tank has 6,600 liters of oxygen if it's full. And an H tank of nitrous oxide is going to have 15,899, or we can say 15,900. Oh, did you get locked out?
I did.
These are not the typical tanks that we use in the dental office. All right, so we do not use whippets in the dental office, okay? All right, universal gas law. The universal gas law is an equation that can be used to determine how much gas is actually in the tank. We learned about this when we were looking at the oxygen tanks in medical emergencies, okay? And so what we can do is when we look at an oxygen tank, whatever the pressure is on that gauge, we can determine how much gas is in that tank. So if it says 2,000, we know it's full, so we know it has 660 liters. If it says 1,000 psi, then it's half full. So we have 330 liters, right? Okay, so we can use the universal gas law with oxygen in order to determine how much oxygen we have. Now, the universal gas law only works for gases. And we know that when we fill a nitrous tank, the majority of it is liquid. So you cannot use the universal gas law with nitrous oxide until all the liquid is gone. So as you use the nitrous oxide up, there's a little portion of it that's gas. As that gas is being used up, the pressure inside the tank will change enough so that some of the liquid will then become gas. So it evaporates into gas. And so it's going to maintain the same PSI until all the liquid is gone. And that won't occur until there's 25% of the volume left. So we said that when we looked at this in an E tank, there's 1590, we can say approximately 1600. So the PSI is going to stay the same for nitrous oxide until we get to about 400 liters. When we get to 400 liters, that's when the gas gauge is going to start going down. Once that occurs, then we can start using the universal gas law to determine how much we have left. Now the PSI for nitrous oxide is 750 in a full tank. So for the first 75% of the nitrous oxide in the tank, your pressure gauge is going to remain at 750 psi. Once we've used 75% of that nitrous oxide up, we have 25% less. Now it's all gas inside the tank, and so we'll start to see the pressure gauge go down. Is that all making sense to you? Yep, okay. All right, so let's look at the difference between general anesthesia and some of the sedation types of moderate sedation and light sedation, that sort of thing. So with general anesthesia, that's when they're having a complete loss of consciousness. They also lose their pain perception. So a person under general anesthesia does not need to be anesthetized because they're not going to feel pain. Now, when we have a patient in the OR and we do a bunch of extractions on them, we do not need to anesthetize them during the procedure. But then what we do is when we're done, then we anesthetize them. Why do you think we would do that? For post-op pain. So when they wake up, they're not in pain. Okay? They also lose their protective reflexes. So that means they cannot gag. So if we put something in their mouth, it can just slide right down because they won't gag. Sometimes most of the time, they can't breathe on their own either. So a tube has to be put down their throat, and we have to put them on a ventilator to breathe for them. So when we send a patient to an oral surgeon for general anesthesia to have their wisdom teeth out, are they truly getting general anesthesia? they're getting deep sedation. Okay, so we'll look at that. So when we talk about sedation, so that's going to be a reduced state of consciousness. All right? They are not made unconscious. Well, I take that back. With deep sedation, they are. So there is a reduced state of consciousness. But with some of the sedation techniques, the patient is still awake. They're just calmer. Okay? Under sedation, we have minimal, moderate, and deep. So minimal sedation is if this patient is relaxed, we can talk to them, they can talk back to us, having a good time, they're just feeling better. Okay? With moderate sedation, they have that reduced state of consciousness. Sometimes they get so relaxed that they fall asleep, but the medication doesn't actually put them to sleep. Okay? They still, if you talk to them and say, wake up, they'll wake up. Or if you ask them a question and, kind of agitate them a little bit, they'll be able to answer the question. Okay? Yes?
Is that what they would use for, like, wisdom teeth?
Depends. It can be either moderate or deep.
Because I think I had that, because when I'm in those and do that, I fell asleep, I don't remember any of it.
Did you go to an oral surgeon?
Yeah.
They use deep sedation. Yeah, in an oral surgeon's office with deep sedation, then the patient pretty much is unconscious, but they don't lose their protective reflexes. Okay? So if they talk to you, you won't talk back to them. Okay? They don't respond to verbal stimuli. But if you take an Explorer and shove it into the roof of their mouth, they'll wake up. They'll feel that. Okay? So they will respond to pain, but they won't respond to just verbal stimulation. So if you talk to them, they won't respond to you. Okay? So when you go to the oral surgeon, you're getting deep sedation. General dentists we are not licensed to do general sedation. We do either minimal or moderate. Okay? Minimal sedation, nitrous oxide would fall under minimal sedation. Okay, so if you have a patient on nitrous oxide, they're going to be relaxed, but they can have a conversation with you. You don't want them to, but they can have a conversation with you. When we start doing the IV or intravenous sedation, then we're looking at moderate and deep. And again, oral surgeons can do deep sedation, general dentists can do moderate sedation. So when you go to the general dentist, they do an IV. They give you medications. You don't actually go to sleep, but because of the medications, you don't remember what happened. Yes?
So say you were to go and they don't know you well enough, so you will wake up with deep sedation.
With deep sedation? Oh, yeah.
Yeah.
Yeah, you'll come too if they hurt you.
Yeah.
Yes.
And that's why you give them the morphine or the black anesthetic, what you're talking about?
I give them Marcaine when I know that they're going to have a lot of post-op pain. So if I know if it was a brutal extraction, it was a really tough extraction, I know that patient's going to have a lot of pain. Or if I do a root canal, a lot of times with root canals people have post-op pain. So I will give them Marcaine for that. With deep sedation, they can still give you lidocaine.
So they don't feel the pain during deep sedation?
If you have to be anesthetized to not feel pain.
It's both.
Yeah.
Oh, okay.
Yeah, you have to, with deep sedation, you still have to be anesthetized, with local anesthetic.
Dr. Goodwin?
Yeah.
Is that, so like, I was in the operatory once, and I like had this patient, and like every time like something, like he wouldn't wake up or anything, but like when we would start like removing bone from his lower jaw, his hands would like instantly like go to his face, and like I had to like pull his hands down. So is that because he was feeling some type of pain?
It could be that he was feeling some kind of pain, or it's just that, it was a strong enough stimulus.
Okay.
Is that with Dr. Pettit?
Yes.
Yeah,
Yeah.
so Dr. Pettit would have been using deep sedation, but sometimes even with deep sedation, even though they're not necessarily feeling pain, if it's a strong enough stimulus,
Okay.
then they will respond to that.
Okay.
All right, so we have to do a little review of the respiratory system. We know we have the upper airway and we have the lower airway. Upper airway starts with the mouth and the nose. The air will then follow down through the pharynx and then down through, hopefully not the esophagus, but down into the larynx and then down to the lungs, okay? We know that the pharynx is divided up into 3 sections. We have the nasopharynx, which is this area between the nasal cavity. So here's the pharynx area here. So this would be the nasopharynx right up in here. We have the oral pharynx. So when you look in the mouth, you remember where the fauces is? Everybody remember the fauces? Past the fauces, you can see the wall, the back wall of the oral pharynx, okay? In most cases. Sometimes, depending on the anatomy of the patient, you may not be able to. But this is what you would normally see, okay? So here's the fauces right here, right back here in the center. That's the back wall of the oral pharynx. Sometimes you see this, especially in young kids. You see these gigantic tonsils. Who would have a much more difficult airway to manage? This or that? That, okay? Because they're pretty much obstructing themselves, right? All right, and then we have the laryngopharynx. So this is what we're looking for when we go to intubate a patient. We're looking for this area right here because we want to slide that tube right through there to get it down into the trachea, okay? All right, the lower airway, we follow down the trachea. We know we get to the bronchi, and then we get to the bronchioles, and then at the very end we have the alveoli, which are those little air sacs that have that single layer of squamous cells. Does anybody remember what the name of it is? Starts with an M. Ends in mesothelium. Good, mesothelium. All right. And it's thin because it allows the oxygen to travel from the alveoli into the capillaries that are surrounding the alveoli, or we can see right here. And also the carbon dioxide can leave the blood vessels or the capillaries and enter the alveoli to be exhaled out. All right, so now we're going to look at the pharmacokinetics and pharmacodynamics of nitrous oxide. And we're going to define the blood gas coefficient and explain what effects it has on inhalation agents. And then we're going to define MAC, not MAP. We're going to define MAC this time, okay? And how, and its influences. All right, so the first thing we want to look at is that different gases will have different onset times and different elimination, okay? And what they have found is that when the gas goes in and it gets into the bloodstream, some gas dissolves within the blood. So the more the gas dissolves in the blood, the slower the onset of the effect of the gas. Also, the more that the gas dissolves in the blood, the slower the elimination of that gas. And so the blood gas coefficient is an inverse relationship of that solubility. So in other words, what I'm saying is that the lower the blood gas coefficient, the faster the onset and the faster the elimination of that gas. So if we look at nitrous oxide, we can see that nitrous oxide has a pretty low blood gas coefficient compared to some of these other gases. So nitrous oxide has a fast onset and a fast elimination. Okay, so the lower the coefficient, the faster the onset, the faster the elimination. All right, MAC stands for minimum alveolar concentration. So MAC is the percentage of the gas needed to render 50% of the people receiving it unconscious. So if you have 100 people lined up and you're giving them all a specific gas, the percentage that is necessary to put 50% of them asleep is the MAC. So when we look at these three here are general anesthesia inhalation gases. So we can see here that their MAC is 1.2, 6, and 2. So this means for isoflurane, they only have to have the gas on 1.2% in order to render 50% of the people getting it unconscious. Look at nitrous oxide, 105. So how likely is it for someone to be unconscious receiving nitrous oxide? It's pretty darn low. There have to be some special circumstances in order to do that. Now remember that we're talking 50%, so you may have one lightweight that gets put to sleep at 90%, okay? But usually there's other factors coming into play that lowers that, okay? So the MAC for nitrous oxide is 105%. So when we look at minimum alveolar concentration, what we're talking about, what that percentage is, in this case, we're looking at room air. So room air we know is 79% nitrogen, 21% oxygen, okay? Once we put the individual on an inhalation gas, in this case we're using desflurane, which is a general anesthetic, they're receiving 6% desflurane and 94% oxygen. So 50% of the people getting this concentration will be rendered unconscious. For some, they need to give them a little bit more. Some, they can give them a little bit less. They usually don't, because they don't want them waking up in the middle of surgery. Okay? So with nitrous oxide, for it to work on our patients, we only need to be using 0.1 to 0.5 MAC. So basically this refers to, we're going to put our nitrous oxide unit on 10% to 50% nitrous oxide. So for most people, it'll be kind of in general in the middle, about 30%, 30 to 40%. You'll have some that you'll be a little bit higher, okay? But anywhere from 10% to 5% MAC, or sorry, 10% to 5% nitrous oxide is equal to 0.1 to 0.5 MAC. And that's because I did the math. 105 is the MAC for nitrous oxide, so 0.1 times 105 is about 10%. Everybody follow me how I did that math? Okay. Now, if the patient is taking other medications at the same time, that can reduce MAC. So if we give the patient some sedatives or especially some narcotics at the same time that we're giving them the nitrous oxide, that can lower the MAC. So that means that at a lower level, someone could be rendered unconscious. So it may be 90 instead of 105, or maybe 80 instead of 105. If we give them other sedatives at the same time. So they kind of potentiate each other. You follow me with that? Yep, okay. So, these numbers? Yes. So we know that the MAC of nitrous oxide is 105. So 0.1 times 105 is about 10%. 0.5 times 105 is about 50%.
And how did you get to the desflurane? Why is that?
Because when we go back to this this chart here, this is the given. So this max for desflurane is 6. So for desflurane, they only need to give them 6% desflurane in order to render 50% of the people unconscious.
And then nitrogen oxide is how
You have to give them 105%.
Okay, then what's the 10%? What's the 10%, the 50%?
The 10% is when you turn the unit on. So when we turn the unit on, the nitrous oxide unit on, we can put it on a certain percentage of nitrous, certain percentage of oxygen. So if we put the nitrous unit on 10% nitrous, then it's going to be 90% oxygen. If we put the nitrous unit on 50% nitrous, it'll be 50% oxygen. Okay? So the 0.1 to 0.5 MAC would be 0.1 times this or 0.5 times that. That range is a percentage of nitrous oxide that we would be giving the patient when we turn the unit on. Okay? All right, so here's an example. You could have, if you have a patient who is taking barbiturate and narcotics at the same time. So we give this patient a barbiturate and a narcotic and nitrous oxide. We can, at 70% nitrous oxide, we could render somebody unconscious. Okay, so it lowers the MAC. This is if we're just doing it at the same time, okay? I didn't have a question here. What do you think would happen if someone is chronically taking a narcotic? So they've been taking a narcotic for chronic back pain. They've been doing it for 5 years. You'd have to give them a little bit more. And why is that?
Because they're already like on something.
Their body has built a tolerance.
Yeah.
Okay, and we're going to look at how nitrous oxide works, and it kind of works like a narcotic. Okay, and I think it maybe on another slide that I put that. All right, so now we're going to look at the difference between analgesic and anesthetic actions of nitrous oxide, and then we're going to talk about what happens when nitrous oxide is distributed into areas of the body that are called air-filled spaces, and then we're going to look at respiratory and cardiovascular function. All right, so what they have determined is they don't know. Okay, they looked at how nitrous oxide causes sedation and general anesthesia in the cases where someone is rendered unconscious, and they have no idea what the mechanism is. They just know it works. Okay, they do know the mechanism for analgesia and how it works. And what they have found is that it works centrally, just like a narcotic does. So they have found that 30% nitrous oxide is equipotent to giving someone 10 to 15 milligrams of morphine IM, so intramuscularly. So what they have found that it does is that when someone receives nitrous oxide, it causes the release of endorphins. The release of the endorphins will actually trigger the release of norepinephrine. Norepinephrine inhibits painful stimuli. So that's how it affects the analgesia. If you injure yourself, if you're on enough nitrous oxide, you won't feel it. They've also, in this study, they determined that if someone is on nitrous oxide and they give them Narcan, it will actually block the influence of the nitrous oxide, at least the analgesic part. It doesn't block the sedation or general anesthesia part, but it does block the analgesic part. Okay? You all follow me with this? Good? Okay. All right, so now we're going to talk about something called diffusion hypoxia. And theoretically, diffusion hypoxia could be a very serious problem. So what happens is that when a person breathes in room air, by the time that oxygen gets to, this is not a beaker, this is an alveoli, okay? This is the best alveoli I could find. All right, so once the oxygen gets to the very base of the alveoli, it's about 14%. And so about 14% oxygen is going to get into the blood vessels, okay? So then we start someone on nitrous oxide. So when we start someone on nitrous oxide, what will happen is the nitrous oxide, we know that it's inert, so it goes in and comes out exactly the same way it went in. So the nitrous oxide can go back and forth. The oxygen obviously is used by the body, so the oxygen doesn't go back out, it stays in, okay? So during the induction of nitrous oxide, we have oxygen going into the bloodstream, and we have nitrous oxide kind of going back and forth, okay? When we take someone off of nitrous oxide, what happens is because it's such a fast elimination, the nitrous oxide that's floating around undissolved in the bloodstream is going to leave almost all at once. So theoretically, what can happen is all that nitrous oxide can fill up those alveoli, which is going to prevent more oxygen from coming in, and the person will have what we call diffusion hypoxia. With what the units that we use in the office and the way that we use the nitrous oxide, this does not happen. Okay? It will happen. I think I've got it described here. So we said that the alveolar oxygen is diluted by all of that nitrous oxide that's leaving the capillaries and entering the alveoli. It has been documented when someone was intubated and they were receiving 75% nitrous oxide, or someone was using a face mask, so they couldn't breathe any room air, they were breathing exactly what we were putting in them, okay? So if you have somebody on a face mask, not the nasal hood, the entire face mask, and 75% nitrous oxide. Typically it's going to be a debilitated patient. So you've got a sick patient, you're intubating them and giving them 75% nitrous oxide. Because we're using nasal masks and the nitrous units that we have will not even allow us to go over 70% nitrous oxide. So because we're not intubating our patients, we're not using face masks when we give them nitrous, and we're not going over 70%, it's not going to happen. It's very unlikely to happen in the dental office. I'm never going to say not. You know, there's always that weird case that happens, but it's highly unlikely. All right, so now diffusion into air-filled spaces. When we breathe in, we have air-filled spaces in our bodies, okay? So as we breathe in, think of like our sinuses and our the areas in the pharynx and that sort of thing. We have spaces where some of that air goes. It doesn't all just travel straight down into the lungs. So when we breathe in and breathe out, we will have some of the gases that go into these air-filled spaces, all right? When we give nitrous oxide has been found to go into those air-filled spaces actually much higher than what the normal room air would. So if the air-filled space is just lined by soft tissue and can expand, it's a non-issue. But if it goes into an air-filled space that has bony walls, that pressure can cause pain for an individual. And so this pressure could occur in the middle ear. Sometimes patients will complain of pain in the middle ear. Sinus cavities, because we know that there's bony walls of the sinus cavities. And they've actually done some tests and found some gas bubbles in patients that had some ophthalmic procedures, okay? So we just have to be aware that we don't want to, when we're giving someone nitrous, we want to be aware of how much we're giving them as far as the gas volume goes, okay? And we don't want to overdo it because they can only breathe in so much. And if we're giving them over that, then it's going to fill in those gas-filled spaces, or those air-filled spaces more. All right, so now we're going to look at some cardiovascular and respiratory influences of nitrous oxide. So when someone is receiving nitrous oxide, it actually will cause an increase in the rate of their respirations. So they'll breathe a little bit faster. It also decreases tidal volume. So when they're breathing a little faster, they're not breathing as deeply as what you normally would breathe. And how do we determine minute volume? Rate times, there you go. All right, so one other thing that it does is that it will depress the ventilatory response. And that is when we talk about the hypercapnic and the hypoxemic drives. And remember, what do most healthy people, which drive do they use? Are we controlled by the carbon dioxide in our body or the oxygen in our bodies? Maybe carbon dioxide, yeah. For most healthy, normal individuals, the hypercapnic drive is what causes us to breathe. So when our body, the sensors determine that there's too much carbon dioxide in the body, we exhale that and inhale oxygen. Some sickly individuals, especially people with COPD, sometimes they lose that hypercapnic drive and they follow the hypoxemic drive. The hypoxemic drive means they have a lower level of oxygen, which then causes them to take a breath. So what they have found is that with nitrous oxide, with the depression of the ventilatory response, it affects the hypoxemic drive much more than it does the hypercapnic drive. Now, even though there are some changes in the respiration, it's really a non-issue. It doesn't change it enough that it's going to affect the normal healthy individual. Okay? So this is just showing you the depression of the hypercapnic and hypoxemic drives. So if we look at the normal MAC, which is going to be 0.1 and 0.5, 0.1, 0.4, somewhere around there is the normal MAC. Remember, that's 10 to 50 or 10 to 40%. And we can see that this green line, this is the hypoxemic drive and this is the hypercapnic drive. So all this is showing you is that it depresses the hypoxemic drive a little bit more than it depresses the hypercapnic drive. That's all this graph is showing you. So when we look at tidal volume, now this is looking at not only nitrous oxide, which is the red line, but it's also looking at 3 of the general anesthetic inhalation gases. And so at normal MAC for nitrous oxide, we can see that there is a depression of the tidal volume, so we don't breathe as deeply. And we see that there is an increase in rate. So we breathe a little faster. So when we look at the minute ventilation, which is, go back to this, tidal volume times rate, we can see that minute ventilation is a little bit higher. So we've got decrease in tidal volume, increase in rate, but the final effect is a slight increase in minute ventilation. So we're actually getting more oxygen when we're using nitrous oxide. The other thing that we want to remember is when we're using the units that we use in the dental office, we have the patient on a nasal hood. We turn the machine on, and say we turn the machine on to 50%, okay? So in this case, the gas machine says that the patient is receiving 50% nitrous oxide. By the time it gets through the tubing and everything to the nasal mask, some of it gets sucked through into the scavenger. The nasal mask only has about 22% nitrous oxide. Once it gets into the pharynx, because some of it goes into air-filled spaces, once it reaches the pharynx, we're about 17.5%. Once it gets into the alveoli and into the capillaries, by the time it gets to the venous blood, we're looking at about 8 to 9%. So when we have a unit on 50% nitrous oxide, that doesn't mean that the patient is receiving 50% nitrous oxide. In their blood, they're receiving about 8 to 9%. Okay? So let's look at the influences on the heart. So it says the negative inotropic effect offset by release of norepinephrine. Okay, so what does inotropic mean? Force of contraction. So what would be negative inotropic effect? Decreases or reduces the force of contraction. Okay, so nitrous oxide reduces the force of contraction of the heart. But we also know that it causes the release of endorphins, and the release of endorphins triggers the release of more norepinephrine. What does norepinephrine do to the heart? It's sympathetic. Increases the force of contraction, right? So it offsets it. All right, this could be a problem if you have somebody with severe congestive heart failure. Because of the release of this norepinephrine, it could be a problem. So if you have someone has severe congestive heart failure, they may not be a candidate for nitrous oxide.
Would it make a difference if they're taking the medication with positive inotropic? Would that cause issues?
It wouldn't like counteract or cause or issues with the medicine. It's more of the condition. So it's not like it's going to prevent the medication from working or something like that. All right. So if the patient is also taking opioids, opioids will suppress the release of norepinephrine. All right, so let's look at the cardiovascular influences. We're going to look at stroke volume and heart rate. Again, the red is nitrous oxide. So with normal MAC, we can see that there's a decrease in stroke volume. When we look at heart rate at normal MAC, we have no change at all. So if stroke volume is decreased and there's no change in rate, what would we expect to happen to cardiac output? First of all, how do we determine cardiac output? Stroke volume times rate. So if stroke volume is lowered, heart rate stays the same, what's going to happen to cardiac output? Yes, it's going to go down. It's going to reduce it. And so we'll see that. Cardiac output goes down. Okay? So would this be a good medication for someone who is having angina? Yeah. Because the heart's not going to be working as hard. Plus, we're giving them oxygen. All right. And so when we look at mean arterial pressure, if we know that cardiac output went down, right? How do we determine MAP? MAP is determined by that equation. Two times diastolic plus systolic divided by 3. Yes. And how do we determine systolic blood pressure? Cardiac output. Yes. Cardiac output determines or cardiac output determines the systolic blood pressure, and like you said, cardiac output is volume times rate. So we already know that we reduced cardiac output. So if we reduce cardiac output, what is that going to do to the the systolic blood pressure? It's going to decrease it, right? And if we decrease systolic, in the end, diastolic's going to go with it a little bit, right? So mean arterial pressure is lowered. Why do you think it's not lowered as much as like this is lowered? Because it's affecting systolic more than it's affecting diastolic. And when we do that equation, it's 2 times diastolic plus 1 systolic. So it's reduced, but it's not reduced as much because we're actually affecting more systolic than anything. All right, so does everybody understand the respiratory and cardiac influences? You see how we kind of thought it through and figured that out. So we don't have to memorize those charts. We can just think it through and figure out what the correct answer is. Yes?
So like, testing purposes, do you want to know what all the other ones?
The inhalation, no. The other general anesthetics, no. No.
So the only real negative is just if someone has congestive heart failure.
For now. For now. We're going to talk about some contraindications here in a little bit. Okay, so let's look at what happens when we receive toxic levels of nitrous oxide during chronic exposure. So what's the thing everybody freaks out about when someone's using nitrous in the office?
We're gonna throw up.
Well, I'm talking about not the patients so much, but the employees, the female employees. Are you pregnant? And it's like everybody freaks out that they're pregnant, they have to go over to the farthest corner of the office to stay away from it, okay? Well, we're going to talk about that. So when I discuss these things, I'm talking about chronic exposure. This is not one time working in the office with a patient who's receiving nitrous and we're using the proper scavenging techniques. We're talking about chronic exposure to toxic levels of nitrous oxide, okay? There is some effects to certain tissues. So when people are receiving chronic exposures to nitrous oxide, we can have some hematological issues with certain anemias. We can have some neurological issues where people start to get some tremors. And there can be reproductive issues with either getting pregnant or having a miscarriage during pregnancy, okay? Again, chronic toxicity. What happens is, first of all, chronic levels of nitrous oxide will inhibit this enzyme called methionine synthetase. And methionine synthetase if it's inhibited, there won't be as much DNA synthesis occurring, and because of that, we don't get as many of the blood vessels forming, and so we end up with certain anemias. It also can cause a reduced production or formation of the myelin sheath that has to be over some of the nerves, and because that myelin sheath is a protective covering, and if they don't have that myelin sheath, then that's when we can get the neurological issues where people start getting tremors. And then chronic levels of nitrous oxide can cause diminished uterine perfusion, so not enough blood flow to the uterus, which could possibly cause a spontaneous abortion. Again, chronic levels, okay? The other thing that nitrous oxide can do in chronic levels is it can inhibit this hormone called luteinizing hormone releasing hormone. If we reduce or inhibit that, then we'll look at the cascade that causes ovulation and how it's going to affect that here in just a minute. All right, so, and actually less than a minute. So the hypothalamus releases the hormone called luteinizing hormone releasing hormone. That stimulates the pituitary to release luteinizing hormone. Luteinizing hormone stimulates the ovary to ovulate and to release progesterone. So chronic levels of nitrous oxide can inhibit the release of luteinizing hormone releasing hormone. So if we reduce this, then we're going to reduce everything else down the cascade. So if someone is receiving chronic exposure to nitrous oxide, they could have problems with becoming pregnant. The other thing that nitrous oxide does, we already know it stimulates the release of norepinephrine. So if they have toxic levels, then we get an even more increased level of the norepinephrine. Norepinephrine can cause lowered perfusion of blood to the uterus, which then could possibly cause a spontaneous abortion. And I repeat, chronic levels. You're either in an office that is not scavenging correctly, you are abusing nitrous oxide. So it's either you're doing something that you shouldn't be doing, or you're in the office is not appropriately scavenging and removing the nitrous oxide. So this was a study that was done to determine how long it took people to get pregnant. And they were looking at people that either worked in an office that never used nitrous oxide. They looked at an office that had a low use, which means less than 5 hours a week, but that office used the proper scavenging equipment. They looked at offices that had a high level, so greater than 5 hours a week, still used the proper scavenging equipment. They looked at offices that had a low level of use, but they were unscavenged. And then they looked at offices that had a high amount of use and were unscavenged, okay? And so what they looked at is, here was the number of women that worked in all of these offices. And then they looked at how many months it took them to get pregnant. They also looked at how many or what percentage got pregnant the first time. And then they looked at how many or what the percentage was that it took over 13 months to get pregnant. So if you look at this, we can see that in people that worked in offices that used no nitrous oxide, on average it took 6.4 months to get pregnant. In offices that used a low amount of nitrous oxide but were properly scavenged, it only took 4.7 months for them to get pregnant. Does that mean nitrous oxide helps you get pregnant? No,
Yes.
no, it just no, it doesn't.
Yeah,
It gives you endorphins. You may not care who you're with. I don't know.
Endorphins.
Yeah. The thing or the big thing with this article is the number of months that it took an individual, or on average, the women to get pregnant in offices that used a high amount of nitrous oxide and were unscavenged was 32.2 months. So it definitely extended the time because they were not releasing that luteinizing hormone releasing hormone. Okay? This is chronic levels of nitrous oxide. These two here would be a normal office using the proper scavenging techniques. Okay? And you can see with those, it's pretty even with the unexposed offices. The number of, or the percentage that got pregnant the first time, there still were 11% still got pregnant the first time they tried, or the first month. and then 42% took greater than 13 months, okay? So what this is showing you is that, yes, if you have a high or chronic exposure, and in this case, high levels in unscavenged office, it is going to affect your chances to get pregnant. But if you're in this office or this office, it's about the same whether you're in an office that uses nitrous or doesn't use nitrous. So what can we do to minimize that chronic exposure? Well, one, we can do environmental monitoring, okay? There are some agencies that do have rules as far as how many parts per million can be in the area. OSHA still does not have any levels. So there is no OSHA rule. There's some technical things that you can do, making sure that you're using the proper fitting nose piece. You know, there's technical things that you can do, your technique, and then the equipment, making sure the equipment is working properly. So this is, they did some tests on many different brands of nasal hoods. And they looked at they tested the amount of nitrous that they found in an area when these specific masks were used. The ones that we used here, the ones that we used here are the Porter masks. The thing to remember is what is right down here, is that in all of the literature, there has been no known adverse effects for anyone working in an area that had a level less than 500 parts per million. And this is a chronic exposure. So they've done research on this and they have found no adverse effects in less than 500 parts per million. All right, some offices may want to do monitoring. There is these room monitors that can be used, or office monitors that can be used. They're quite expensive. Most offices, I highly doubt, are going to use those. Some offices may have you wear a badge, just like you guys wear the X-ray badges, or you have them. I think they're sitting outside the room, right?
Radiology faculty wears it.
The faculty wear it, okay.
Yeah.
And I think there's some
There's
that are
one-
outside the rooms.
Yeah, there's one like outside of E.
Okay.
Yeah, you're right.
Some offices may have you wear a radiology badge. It's not a required thing, okay? But, so I don't know that most offices will use it, but a lot of the institutional type offices will have people wear them. You may wear a nitrous oxide badge too. All right, so we need to think about infection control with the units that we have. The hoses, some of the hoses are designed to be sterilized. The ones that we have are not. The masks, some of the masks are sterilized. You can sterilize, some of them you have to disinfect, and some are disposable. We'll look at our specific one here in just a second. So when you're using the units, you want to make sure that you disinfect the hoses. And then you also want to disinfect anything on the unit that you touch. So when you touch these knobs here, you want to make sure that you are that you disinfect those when you're done. All right, so with the masks, they used to make these little paper things that you stuck underneath the mask, but they were quite annoying, and they don't even sell them anymore. But and then there are different types of masks. These are disposable. This one is a unit that you have to disinfect. This is the kind that we have. So there's an outer hood and then there's an inner piece. The inner piece is designed to come out and be sterilized. The outer piece is designed to be disinfected. We sterilize ours too, okay? But these are designed to be disinfected on the outside ones. So how do we minimize exposure? Well, in the operatory, some operatories have ventilation. We have air handlers that help to ventilate the room. And then using some sort of monitoring, if you want to use an office or a room monitor or wearing the badges. The technical things are things that you can do. So you want to make sure that you're using the proper sized fit mask. You want to make sure, this is the biggie. Once people get relaxed, then they want to talk. and talk and talk. And so you have to get them to stop talking, because the more they're talking, they're breathing that nitrous out into the room, okay? So you gotta keep reminding them to stop talking. The vacuum setting, we're gonna look at that. The vacuum setting is for the scavenging. The minute volume is how much volume of gas you have coming out of the unit going to your patient. If they only need 3 liters total volume of gas and you're giving them 8, then you're going to get leaks of the gas and it's going to end up in the room. Early termination just means only use the nitrous when you need it. So if they only need the nitrous for when you give the injection, put them on the nitrous, give them the injection, and then turn it off. Okay, they don't need it for the whole procedure. And then equipment, making sure that you have properly maintained and calibrated. Always check for leaks, because sometimes the hoses or bags will get leaks in them. Make sure that you're using the scavenger. And then air sweeps are things like they have on airplanes, where the entire air in the room is removed every so often. And so, but you know, most offices don't have that. All right, so let's talk about the components of the nitrous oxide units and the proper use. So this is an older unit. We don't have this unit here. They did have this at the hospital for quite a while. These are the units that we have here. So the Porter units are what we have here. When you look at them, green means oxygen, blue means nitrous. The good thing is if you have someone who is colorblind to those colors, there are fail-safes on this so that you cannot attach the oxygen tank to the nitrous side by accident or anything like that, okay? So anything that's green on here you know is related to oxygen. Anything that's blue you know is related to nitrous oxide. So the knob on the right next to the green tube is oxygen. The one next to the blue tube is nitrous oxide. There should always be someone in the office whose job is to check the tanks. The last thing you want to have happen is right in the middle of your procedure to run out of gas. And so you always want to check your tanks to make sure that you have enough gas in the tanks. There are safety features on the units. So again, here's green and blue, but if you're not able to see the difference with these, if you look at the holes, we talked about the pin index system with the oxygen to make sure that it's attached when you put it in the oxygen, the emergency oxygen cart. The holes on the nitrous are closer together, so you cannot attach the oxygen to the nitrous side, you cannot attach the nitrous to the oxygen side. They won't fit. If you have an office that's plumbed, the diameter of the plug-ins on the wall are different, so you cannot accidentally plug the nitrous into the oxygen inlet. All right, there are also some safety features on the unit. There is a minimum oxygen flow, so when you are using oxygen, you cannot go below, when you're giving them oxygen with nitrous, you cannot go below 30% oxygen, which means you can't go over 70% nitrous. There's also an oxygen flush valve, so in case there's an emergency, patient's starting to get sick, you want to get them on oxygen right away, you can use the flush, which all it's going to do is blow out the gas that's in the reservoir bag and put in straight oxygen into it. There's also an automatic nitrous shutoff, so if your oxygen tank runs out, the nitrous will shut off so that you cannot give them straight nitrous. For some of the units, you're not able to give positive pressure ventilation. You never want to use the bag that's on the unit for positive pressure inhalation, because that's not how it works. That's just a reservoir bag. And so for the units that we have, if we needed to give somebody positive pressure oxygenation, we would actually have to pull this off, and so you pull it off of here, and then you attach the oxygen hose to that, and then you can use that unit for oxygen. Some of the older units, you cannot use that. You have to have a separate oxygen tank. All right, so that's just showing you removing that, and then you use your regular bag valve mask, and then you can mask your patient using that unit. So when you look at the masks, there is let me just pull this part up here. When you pull this up, you can see that there's 2 tubes on either side. What happens is the gas is going to go into the nasal hood so that the patient can breathe it in, and then it goes out the other tubes, one on either side, to your suction for your scavenging. There is a valve. You can't really see it very well. There's a valve right there so that when they breathe out, it won't go back into the unit. It can only go out the scavenging hose. Okay. There's also a little vacuum setting thing on the hose that you can turn the little dial to make this little ball go into the green. When you have the little ball into the green, you know that you're at the proper level of suction for scavenging. All right, so we're going to look at contraindication and complications. Okay, so medical contraindications. Let's think about this. If someone has an upper respiratory infection, would that be a contraindication to using nitrous? You're both right. It depends. Can they breathe through their nose? If they can breathe through their nose, you can use it. If they can't breathe through their nose, you can't use it. Okay, so it depends. What about if someone has asthma or COPD? It depends. See the little question mark? It depends. It depends on the patient. I didn't really talk about asthma. I'm not sure why I didn't talk about asthma. Oh, we talked about that in medical emergencies. With gases, you know that as the nitrous oxide and oxygen don't trigger an asthmatic attack, but because the gases can kind of dry out the passageways, it could possibly, just the drying of the passageway could possibly trigger an asthmatic attack. It's not the gas, it's the drying. So if you have a severe asthmatic or severe COPD person, they may not be the best candidate for it, but routine patient with asthma is not a problem. What about if they're pregnant?
Probably not.
It's probably not is a better answer. It depends is okay too. With pregnancy, it's not a contraindication, but you don't routinely use it if it's not something that's needed. So if somebody comes in and wants it for a prophy, they're not going to get it. But if you need it, someone is extremely anxious, they've got a bad tooth, we need to extract that tooth, then we may need to do it, because what is happening if we don't relieve their anxiety, what's coursing through their bodies? Adrenaline. Is that good for the baby?
No.
No. Okay. What about congestive heart failure? It depends again. A severe congestive heart failure patient, yeah, could be a problem. Routine is not probably the best word, but someone with just a minor congestive heart failure, probably not an issue. Let's look at some non-medical things. What about somebody in rehab?
No.
Why not?
Even look at like maybe if they did or something.
It feels good and it'll line up with other things that it does.
Remember how we said that it acts centrally like opioids do? And so you have somebody in rehab, you give them nitrous oxide, you could trigger them into relapsing. What about somebody with claustrophobia?
No.
No. With minor claustrophobia? Maybe. But somebody with true claustrophobia, you put something on their face, what are they going to do? Right. All right, this is me. This right here is me.
Are you emotional?
Huh? I'm not emotional. I'm mentally compromised. I'm a control freak. So the minute, I know it shocks you, doesn't it? The minute I start to feel like I'm losing control, I panic and I rip the thing off my face. Okay? That's why if I have a drink, I don't get drunk. I don't like the feeling of losing control. I know. I cannot stand that feeling of losing control. And so I am not a good candidate for nitrous oxide. because the minute I start to feel like I'm losing control, it's got to be done. It's got to be off of me. Okay? So when I was saying that, I'm saying that about somebody,
Amy.
yeah, when I didn't want to say her name because you guys are taping. Her personality tells me that she's probably not a person that would like nitrous. The other person, their personality, it's like, yeah, they could have that. That'd be good. All right, so I'm not gonna say names. Okay, so let's talk quickly. We'll talk about an emergency patient. So we have a 28-year-old female. She's healthy. She's 6 months pregnant. She has acute pain from abscess number 30, and she is freaking out. She hates to go to the dentist. She's scared to death. Can we give her nitrous?
Yeah.
Absolutely. All right, so there's some studies that were done to determine the safety of nitrous oxide with individuals who are pregnant. And so they found that the most important thing is we've got to relay their anxiety or their apprehension. And that can be done by sedating them or pre-medicating them. And we should also make sure that we relieve any pain that we can do. We want to avoid maternal hyperventilation. What happens when people get freaked out? They start hyperventilating. Obviously, if they're very pregnant, we may need to displace that uterus so it's not laying on the inferior vena cava. And we can choose drugs with a long history of safety. And the biggie for us, nitrous oxide. Okay, this one showed that agents 50 to 50 oxygen nitrous oxide mixtures were completely safe for the baby. This one, another study showed administration of nitrous oxide did not have any deleterious effects to a pregnant individual. So what's the protocol? I apologize, this is taking long. Okay, so when we have a patient coming in for nitrous, before the patient even gets there, we need to make sure that we turn on the oxygen and nitrous, check the tanks to make sure that we have the amount that we need, the amount of gas that we need. We go ahead and put the mask and hoses on the unit, and then we insert the scavenging hose into the suction, and you turn on the oxygen, and you have the oxygen turn on, and you adjust the scavenging unit so the little ball's in the green. And then we can turn it off because we don't need it running the whole time. So now we bring the patient in, sit them in the chair, get vitals on them. Make sure you get your vitals on your patient. And then you want to demonstrate the mask for those who have never had nitrous before. Show them how it's going to be this thing we're going to put on your nose. You can adjust it, that sort of thing. I always tell them on the back there's a little seat belt that if it wants to slide around, I'll tighten the seat belt, but I usually don't because then people feel like they're being held down to the chair. You always tell a patient to breathe normally through their nose, not through their mouth. And then explain it's not going to be an immediate thing, it's going to be a slow onset, and then we adjust it as we go up until they reach the level that they need to have. Okay, we'll start the oxygen on 5 to 6 liters per minute before we place the mask on their nose. And then we watch the reservoir bag, just like we did with the oxygen. We watch that bag to make sure that it's not overinflating or underinflating. And then we start the nitrous. So when you first start, you'll put it on 20 to 25% nitrous. Leave them on it for about 3 to 5 minutes. Some patients, you'll never even have to turn the nitrous on. Some patients, you'll put the oxygen on and you leave it on for a couple of minutes and they're like, oh yeah, that's it. And they're like, okay, that's the level we're going to keep you on, okay? So there are going to be times that it's mind over matter, okay? And then as every 3 to 5 minutes go up, if we need to titrate it more, then we go up another 10 to 20%. Don't go too fast, you'll make them puke. All right, so they looked at different concentrations of nitrous oxide and some effects that were occurring. And the effects that we want are these effects up here. Anything below this line are effects that we don't want. So if we get any of these effects, we got the nitrous on too high, we need to turn it down. Okay? So we want to tell them, you may feel some numbness around your lips, you may feel some tingling in your hands and your feet. Sometimes you'll feel like, or sound like people are in a tunnel, you know, talking from you far away, those kind of things. And this was just a study to show the most common percentages of nitrous oxide, and you can see we're anywhere from 30 to 40% was normal for most people. All right, so quickly, just to calculate the gas. In order to calculate the gas, we need to know the liters per minute that we're giving the patient, and divided by the total number of gas that we're giving. So when we are given a nitrous and oxygen, we have a total amount of gas. So say we have them on 8 liters total. And then we're giving them, in this case, let's say we're 9 liters total. Okay, so we give 6 liters of oxygen, 3 liters of nitrous. How do we determine what the percentage is? Well, we can do, oxygen would be 6 liters divided by 9, which is the total. So they're receiving 67% oxygen, and so therefore they're receiving 33% nitrous. So you can either subtract this to get 33%, or you can divide 3 by 9, either way. All right, so when we're bringing them off, okay, so they've been on their nitrous. We know that we have to titrate it slowly because we don't want to make them throw up, right? So we need to stop it now. So do we need to titrate it down? No, because pure oxygen is not going to make them puke, all right? And in fact, if it's an emergency situation, that's what we want to do, put them on pure oxygen. So all you have to do when you're taking them off the nitrous is put the machine to 100% oxygen, and then leave them on the oxygen for about 5 minutes. Then we'll take the mask off and let them just breathe room air for another 5 minutes. Get their vitals again. Make sure that the patient is alert and steady enough to leave the operatory. And this is the biggie. Tell them they should not drive for 30 minutes. Will anybody listen to you? No. They'll go up to the front desk, make their next appointment, and leave, okay? You tell them, you document that you told them, and you're golden, okay? Will something happen? Highly unlikely, highly unlikely. But there could be some remnants of nitrous oxide, and say the patient leaves the office, pulls out of the driveway and runs into a car. And there's nothing in the chart that says that you told them that they have to wait 30 minutes. Whose fault is it going to be? Yours. Because if it's not documented, you didn't tell them. Okay? And so chart, document the percentage of nitrous and the percentage of oxygen, and then document that you told them no driving for 30 minutes. All right, complications. Disinhibition reactions. Okay? Sometimes people have sexual hallucinations when they're on nitrous, okay? I'm not kidding. No, they can have some pretty fun hallucinations, okay? So, the rule of thumb is, you never leave a female patient in the dental chair with a male dentist or dental hygienist without someone being around to observe, so they don't have to sit in the room for you. Or if you're leaving with the dentist, somebody's close enough that they can hear anything untoward's going on. Because there have been times that women have said that male dentists have done things to them that they shouldn't have done, and the dentist never did. Okay, so you want to have a witness. Okay. Now the interesting thing is, you hear a lot of women complaining about men doing things. You don't get complaints about men saying the woman did something to them. Okay, I'm just going to leave it at that. All right? You don't hear those complaints, but you do. There have been situations where females, especially young females, have said that the dentists have touched them or did things that were inappropriate while they were on the nitrous. All right, panic reactions. Okay, raise my hand. Panic reactions, okay? If you start to feel like you're losing control, the first thing you want to do is pull that stuff off of you. All right, nausea and vomiting. That's very common if you titrate it too fast. I worked in an office when I first got out of dental school. I worked in an office where the dentist allowed the assistants to start the nitrous. And I wasn't there very long. But they would look in the chart, oh, it was 50% last time, they'd stick it on 50%, stick it on the patient. And people are getting sick. And it's like, first of all, you guys shouldn't be starting it. Second of all, you gotta titrate it. And so, you know, if you have somebody, you always wanna titrate it up. If you have a kid who's crying, they get all snotty, they're breathing through their mouth, get them cleaned up, you gotta start over again. You gotta titrate it back up again, because once they've stopped breathing that nitrous, they're breathing room air. If you start them back on the same nitrous that they were on, they're gonna puke on you. All right, so if any of these things happen, just stop the nitrous. Just put them on 100% oxygen, okay? All right, so quickly gonna do the map. So this is just a reminder of what's in the tanks. So we need to determine if the oxygen says 500 psi, how many more minutes of oxygen do we have? Again, we can use the universal gas law to determine that. We know that 2,000 psi is a full tank, which is 660 liters. And so 500 psi would be a fourth of that. So that means we have 165 liters left. We then need to know what's the oxygen flow. If our oxygen flow is 5 liters per minute, we divide 165 by 5, we get 33 minutes. We have 33 minutes of oxygen left. Okay, that's just a reminder or review from what we did in medical emergencies. Okay, now nitrous is a little different. Okay, so we know that nitrous tank has 750 psi, and an E tank has 1,590. We're going to round it up to 1,600 to make math easy for you guys. We have to wait till the pressure starts to drop. So until the pressure starts to drop, we have no idea how much gas is in there. Okay? Once the pressure starts to drop, we know that we have 25% left. So the minute that gauge starts to go down, we know that we have 400 liters of nitrous in that tank. Now we can use the universal gas law to determine how much we have left. So if the nitrous flow is on 4 liters per minute, then we know that we have 100 minutes remaining. If it's an H tank, whether it's oxygen or nitrous, with an H tank, you just multiply times 10, and that's how many minutes you have left. Okay. And this is just a reminder. Okay, so again, if the PSI says 375 on an E tank, then we know it's half of it is remaining, so there's 200 liters left. If it's an H tank, it would be the 200 times 10, it should be 2,000. All right, we made it. I know that's the longest lecture that I do for the semester. You thought what?
I said October 5th was also the same amount of time.
Oh, was it? What was October 5th? Opioids?
Yeah.
Oh, okay.
Oh. Something about.
All right, any questions about that? All right, you get a 3-minute break until Miss Everett starts.